practitioner and as well as he's national level speaker also on behalf of IAP TNSA. Welcome, sir. And I welcome Dr. PRJ Kannan, sir. He's a well-known cardiologist from Madurai. I welcome Dr. PRJ, sir. And today is another moderator, Dr. Balasankar, sir, for this wonderful program of cardiology. And I, on behalf of IAP TNSA, welcome one and all. I think Dr. Balasankar, sir, has joined. Sir, Dr. Balasankar, sir, can you talk? Yeah.
Sir, vanakkam, sir.
Yeah.
Vanakkam.
Vanakkam,
Sir,
sir.
I'm driving
Vanakkam,
actually.
Yeah.
Vanakkam. Sir, good evening, every one of you. I'm sorry. I have to attend a reception which is far away from my place actually. So I am coming back fast to my house. I am driving. Okay. Thank you very much. And I'm very extremely honored to host this IAP action plan. That is a chat with specialists, because in everyday practice we'll have so many doubts. So it is better, why can't we clear it from the specialist who is expert in that field? That is what it came to my mind, and that is how I organized this one. And as a first event of this program, Dr. This month we are done in cardiology. Okay, and the person who is the resource person today, Dr. PRJ Kannan, a good friend of mine, is a renowned pediatric cardiologist and intensivist who is from Madurai. And his way of explaining things are very simple and clear. That's what I like him most. Okay, so I thought he'll be able, the right person to clear majority of the doubts that's running in the minds of general practitioners. So I hope this meeting will be a very useful one for every one of us who are attending it. And I thank Dr. Padmanabhan sir for his fantastic effort, great effort he has put on. And I hope to join once again very soon. I'll keep on I'll be joining completely within few minutes. Thank you very much. I wish this program a grand success. I'll join soon. Thank you.
Thank you, sir.
Safe driving, but safe driving.
Thank you, sir. Thank you, sir. Over to our academic coordinator, Dr. Murugesh Lakshman. Dr. Murugesh Lakshman.
Good evening, everyone. As President sir told, it will be a very useful program for all the practitioners. So, design the program such that all our day-to-day doubts which arise in a common practice every day is cleared in this program. So, this month we'll be seeing cardiology. And every month we'll be having one specialty. We'll focus on one specialty. And we request all pediatricians to post any questions, queries in the given email ID so that everyone can be benefited. When you get clear your doubts, others also are clear out their doubts. So, I think we'll start with the program.
Tirumurugan.
Yeah. Sorry, Cholunga.
I am a co-host. I'll share the screen and introduce the thing.
You already are co-host though.
Sorry, right. Okay. Is my screen visible? Hello?
Yeah, it's visible.
Yes, sir. Visible, sir.
Very good evening, one and all. I thank the State President, Dr. Balasankar, and our Dynamic Secretary and the office bearers for giving the opportunity to kickstart the program without wasting time. Today's actually the person who is behind the show is main person is Dr. PRJ Kannan today. We all know he is the person who did his MBBS from Madurai Medical College and MD from a prestigious PG Chandigarh and DM Cardiology from Sri Chitra. And he had actually plenty of merits for his thing, and a Commonwealth Fellowship from Guy's Hospital, London, and Best Challenging Case Award at Washington. And he is known for his simplified teaching. That is the best part, is he's interested in teaching and his simplified teaching, and really attracts everyone, particularly the postgraduates as well as the practitioners. That is the reason he has been chosen today. Now, to start with, and if you want to make a difference in pediatric cardiology, you should diagnose heart disease in neonates and young infants. And most of the children, CHD, do not have murmur. This is the statement actually put forth by PRJ Kannan itself in one of the CMEs. And as a physician, we mainly think about structural heart disease, and murmurs are synonymous. But in fact, majority of serious congenital heart disease do not present with murmur. They have murmur is absent in these conditions. So the priorities for a pediatrician is from making an accurate diagnosis to mainly essentially that a potentially serious heart disease is not missed in the early life and the neonatal period, because sometimes it can present as late as 27 days, 28 days. So only even a practitioners come into picture, not only the neonatologist. So we should be aware and suspect and detect and promptly take care of these neonates, because and these are totally curable. Particularly the lesions like TAPVC and TGAs are totally curable, and we can give a life for 7 decades or 8 decades. That is the specialty of the picking of the CHDs. And heart disease can be a critical and non-critical. To start with, the critical CHDs, and most of the critical CHDs present without murmur. And I like to have the timing and presentation in the form of a real-world case snippets from BRJ, sir. And the stage is yours, sir. And over to BRJ.
So very good evening, everyone. Ellame therinja faces tha. I feel very familiar with the people here, and I'm very happy to be part of this. Whenever it comes to knowledge sharing, I make time to attend rather than see whether I have a time. So I am indeed very happy to be part of this. As we have discussed earlier, I think my screen is visible, isn't it? Yes, so we'll go with this case 1.
Visible and audible.
We'll go with this case 1. 5-day-old boy. History of poor feeding and lethargy since 5 to 6 hours. No fever, vomiting, or any other significant history. This boy was delivered at term, normal vaginal delivery, 2.8 kilogram at birth, and discharged on day 3 of life. That is, day before yesterday they came home, and today he is having these symptoms. Okay. Now, on examination, generalized duskiness was there, severe lethargy, poor reflexes, all peripheral pulses palpable, CVS RS clinical examination, nothing abnormal detected. Okay. The usual impression of such a child comes, the usual impression is probable sepsis. I'll just leave this image for some time. Okay. This history and examination, whatever I given. And one very important thing is missing. Okay. What important data is missing here?
Saturation.
The important data which will give clue. Yes?
Saturation.
Excellent, excellent. See, oxygen saturation measurement becomes a part and parcel of any child, any sick child. Oxygen saturation tells us so many things. It's a part and parcel of any important child. Now, just note this. The child was discharged on day 3, that is day before yesterday. Today, the child has come with such a very sick status. No infection can be so florid for a term baby of normal weight, delivered by normal vaginal delivery, to create such a significant septic-like symptoms. Okay. So what are we dealing with? Dr. Palandaman has been kind of very clearly has shown the slide where he said, if you want to reduce the neonatal mortality or infant mortality rate related to cardiology, you should be diagnosing heart disease in children in less than 3 months. If you diagnose, sorry, I won't say diagnose, if you suspect, that also he clearly showed in one of the slides. It's not accurate diagnosis of cardiovascular system is needed. It's mere suspicion that is there or can there be any congenital heart disease. That is enough. Subsequently, child will be diagnosed and properly done. There are other ways to go through. The problem is the suspicion is not there. The moment you suspect, you will go towards the right pathway in diagnosing the heart disease. The important pathway is missing saturation. Let me go through this. See the circulation. This is a normal heart where the right atrial desaturated blood goes to the lungs. Left atrial saturated blood goes to the aorta. Now here the connection between the right ventricle and the pulmonary artery is not there. Pulmonary artery is here. But unless the blood goes into the lungs, nobody can survive. So nature has given a patent or the ductus arteriosus through which the aortic blood enters the lungs, keeps some saturation and keeps the patient or child alive. So in the first 3 days when the PDA is open, nothing happens. Child is like any other normal child because there won't be any murmur. Mild systemic desaturation may be that which may be missed and child will be okay. Now imagine what happens to this PDA closure. If the PDA closes on day 4 or day 5, what happens? Suddenly there is significant drop in the PA blood flow. Okay. That is why a child who was absolutely normal looking on day 3, On day 5, he typically presents with very sick status, and the progression of the disease is so fast, just few hours. So this is duct-dependent pulmonary circulation. Development of cyanosis, rapid worsening, unremarkable otherwise, child with sick looking and acidotic, misdiagnosed sepsis commonly. Now that was duct-dependent pulmonary circulation. Now same thing, if there is obstruction in the left heart disease, okay, this condition is called hypoplastic left heart syndrome, or you take this condition which is called interruption of aortic arch. Now the systemic blood flow is maintained by the PDA. Earlier in the duct-dependent pulmonary circulation, the pulmonary blood flow was maintained by the PDA. Here, the duct-dependent systemic circulation, is maintained by the PDA. Here also, at the time of discharge, child will be normal. The moment the duct closes, there will be severe reduction of the systemic blood flow, and child will present with cyanosis. Okay, so they will present with a shock-like state. But here, in duct-dependent systemic circulation, there will be disparity of pulses. Upper limb may be having better pulse, and lower limb may be having a feeble pulses. Whereas in duct-dependent pulmonary circulation, there won't be any difference in the pulses. Both will have same kind of desaturation. Just one important point I'm going to highlight now. Femoral pulse that was normally palpable on day 3, that is, you are a very good pediatrician. At the time of discharge, you have seen the saturation around 95%, you are happy. And you did palpate the femorals and said it was femorals or even dorsalis pedis was palpable. You have made a record also. Dorsalis pedis palpable on day 3. That doesn't mean there is no coarctation. That doesn't mean there is no interruption of aortic arch. Because once this PDA closes off, the pulse which was palpable on day 3 will become not palpable, impalpable on day 5. So this is an important point to be remembered. Just because we have found a very good femoral pulse at one particular point of time, it doesn't mean or it doesn't rule out a coarctation of aorta. So a simple rule is that a relatively well child presenting dramatically between 2 days to 1 week of life with cyanosis or shock strongly suggests duct-dependent lesion. Okay. Now, again, I'll go to another scenario, again the newborn scenario, case 2. So one point is a relatively well child presenting dramatically within few hours of worsening. Please, even if there is no clinical clue, even if there is no sign of anything, X-ray normal, ECG normal, everything normal, you are supposed to get an echo and rule out a congenital heart disease. So case 2. This is a 2-day-old child. Saturation was found to be 68% in the right upper limb at the NICU, around 10 hours of life. Child was delivered normally, cried normally, normal Apgar score. At the time of delivery, child had done any murmur, anything. So child was kept under observation for NICU for some reason. In the NICU during routine evaluation or routine saturation monitoring, they found it was 68%. No clue clinically, no murmur. The pediatrician took the chest X-ray, it was normal. Anyway, he asked for an echo because he knew that when the chest X-ray is so normal, why should there be a desaturation? That means he is dealing with some congenital heart disease or some heart disease. So he gets an echo done. Echo shows mildly enlarged right atrium and right ventricle, PFO shunting right to left, severe pulmonary hypertension. The impression was severe primary pulmonary hypertension. So in severe primary pulmonary hypertension, there can be RA-RV enlargement and there can be shunting of blood from right atrium to left atrium causing systemic desaturation. But pediatrician was not convinced. He has seen so many primary pulmonary hypertension. No one had a saturation of 68 and all. They may have some 88 or they may have some 85 and things like that. They cannot 68. So he wasn't convinced. So he referred this child to us for second opinion. Okay, this is a kind of routine chest X-ray. Kind of some thymus shadow is there. Some mild CT of cardiothoracic ratio of 60% is normal in a newborn. So this is the chest X-ray. So there was no clue from the chest X-ray also. But I am telling that child is harboring a serious congenital disease. So what is your guess? I am just putting back the previous slide. See the echo report. Can anyone guess what could be the serious congenital disease this child is having? Any comments, sir? Anything can be commented. I have given one group of disease. There is another group where the echo is not able to identify.
TAPVC.
Okay, TAPVC is one condition. What else can be? Another closed DD. Another closed DD is similar to TAPVC. TAPVC is definitely under. I am very happy that most of you got it. Another closed differential diagnosis on day 2 presentation is transposition of great arteries. See, as we all know, the pulmonary artery is connected to the LV and aorta is connected to the RV. RV is pumping directly into the aorta, and hence aorta is having a desaturated blood. Pulmonary is getting back the saturated blood. And when they do the echo, the right atrium, right ventricle, left atrium, left ventricle are normally positioned, and right atrium, right ventricle are mildly dilated. Now, what is very important is they also will see the two great vessels. But what is more important, which great vessel is originating from which ventricle? That needs some precise echocardiography. Not everyone will kind of, a casually done echo cannot diagnose a transposition of great arteries. Unless somebody thinks, okay, I want to rule out a TGA, and then he does the echo, he'll pick up the transposition of great arteries. So anything diagnosis related to the atria, intra-atrial septum, ventricle, interventricular septum, mitral valve, tricuspid valve, they're easily diagnosed by most of the echocardiographers. Even if you have an adult echocardiographer, he'll be able to pick up all these diseases related to right and left atria, related to right and left ventricle, related to mitral and tricuspid valves. But whenever there are diseases related to the great arteries, many a times, unless they are very particular to look for the great vessel, they may miss it. So this child had transposition of great arteries. Again, exactly same. See, the same 5-day-old girl, saturation was found to be 68% in the right upper limb at NICU. No clinical clue, no murmur. Echoes was the same findings. Enlarged right atrium, right ventricle, PFO shunting right to left, severe primary pulmonary hypertension. But pediatrician was not convinced because he had a clue with the chest X-ray. In the previous example, I said there was no clue, but here I am saying there was clue with the chest X-ray. And see, the chest X-ray is very, very obvious. 100%. So all you are kind of very senior pediatricians here, but I wanted all my students and other recently finished our younger colleagues to see this X-ray and make a kind of permanent image of this picture in the brain. Here we see heart, we see some kind of borderline cardiomegaly, and you see that uniform haze of both lungs. Okay, this child could be having anything kind of ARDS-like picture, but that can be lung disease, that can be cardiac disease also. Even if you are sure that the child is having lung disease, if you have this kind of X-ray, it is prudent that you do an echocardiography and rule out TAPVC. As we all know, this is the TAPVC. The pathways from pulmonary veins are obstructed. So obstructed TAPVC will present this early, within 1 week. Unobstructed TAPVC will present slightly later, maybe beyond 1 month. Okay. So the obstructed TAPVC, transposition of great arteries, and duct-dependent lesions, these three form major chunk of treatable congenital heart diseases in the newborn. Okay. So I think I'll stop with this for the initial critical heart diseases. And along with that, I'll finish this oximetry screening because there was one of the question on oximetry screening. So how often we should do? Obviously, we have to do it pre-discharge. No need to do on day 1 or day 2. Maybe there can be abnormality. I mean, there can be persistence of some amount of pulmonary hypertension, persistence of right left shunting. It is said that beyond 24 hours, you should not have a desaturation. That is saturation more than 93%, but still there are high false negativity and false positivity. We are discharging the child on day 3 or day 4, isn't it? So let us have the pulse oximeter record on pre-discharge. Then when the child comes for the first vaccination, 6 to 8 weeks, again another pulse oximetry. Okay. If one of the two is abnormal, if both are normal, we are ruling out all cyanotic heart disease. I can be very sure. The cyanotic heart disease can be a severely cyanosed heart disease like tetralogy of Fallot, or can be a mildly cyanosed single ventricle or tricuspid atresia also, so-called admixture physiology. So all the TOF physiology or admixture physiology, they will get exposed by 6 to 8 weeks. So at 6 to 8 weeks, if you are having a normal saturation, we have definitely ruled out a cyanotic congenital heart disease. If anyone is abnormal, that is initially itself it was abnormal, but initially normal, but later becomes abnormal, that becomes an indication for echocardiogram and pediatric cardiology evaluation, even if the child is totally asymptomatic. Okay. Okay. So before I go to the next case, if any question regarding these things, if you have received, sir, Dr. Palanraman, through the email something, we can discuss this, and then I can go for the next case.
No question, sir. You can proceed, sir.
Okay, regarding this so far. Okay.
Yeah. Yes.
Right. Okay. So I think I am clear in saying that in the newborn period, as we have said earlier itself, we should not depend on Murmur to diagnose congenital heart disease. any serious sick child, you may be having whatever may be the initial diagnosis or admission. Let it be whatever may be the acidosis, let me be some urinary infection or some septicemia or IC bleeder, whatever may be your initial diagnosis. You start treating according to your initial diagnosis. But by 12 to 24 hours, you should see some improvement because of your treatment based on the initial diagnosis. If you don't see the improvement, please think that it can be something more than what you have diagnosed. And the first thing to come to your mind should be heart disease. I'm dealing with a heart disease because the child is not responding to my usual treatment. Please get an echo done. Nowadays, we don't see, always it's easy to get a chest X-ray, no problem, but it has its own use and also false negativity also. But echo is also very easily available, the screening echo. In fact, in one of my lectures, I regularly take screening echo to be done by pediatricians, and I'm teaching pediatricians how to do a screening echo also. Okay, now this is case 4, 2-month-old boy. Okay, now we have come beyond the neonatal period. 2-month-old boy, poor feeding, poor weight gain, increased pericardial activity, saturation normal. Okay, so all these things, as we all know, these are indicative of heart failure. These are also indicative of increased pulmonary blood flow. Saturation 96%. Echo showed a large VST. I have already given the diagnosis. Now, just to give this one clinical aspect of it, what would be the murmur on CVS examination on this child?
Usually
Will
no
there be any
shunt murmur. No
Yes,
shunt
sir?
murmur, only flow murmur will be there.
So what murmurs? It will be a diastolic murmur, a systolic murmur, a ejection murmur, a
Just
pansystolic
systolic
murmur.
murmur in the pulmonary area. Systolic murmur in the pulmonary area.
Excellent, very excellent. So that's the only thing will be there. So there will be a short ejection murmur at the pulmonary area because of the increased flow in the pulmonary artery. There won't be any other murmur. So unless somebody listens to this carefully, he might miss it that as though it is a respiratory problem. The child may be having a respiratory infection also. Child would have actually come with pneumonia. A child with pneumonia will have the same kind of, clinical finding, isn't it? Poor feeding, poor weight gain, and increased pericardial activity will be there. Unless the pneumonia is extensive, saturation can still be maintained. Okay. So if the physician is not keen on listening to the chest or he doesn't listen to the chest, he'll start straight away treating as pneumonia. Chest X-ray also shows pneumonia, but the child will not improve just because you are treating for the pneumonia. So the clue here will be a short systolic murmur, and one should not expect a long and loud pansystolic murmur for a large ventricular septal defect. Okay. Now, this I'm going to stop. This just to complete the interesting cases. I put as case 5. It's a 6-month-old girl. Mother has come back to in-laws' house. Okay, so she went to her mother's house for delivery. Child has been delivered and child was normal. Mother has come back to the in-laws' house. Found to have a murmur by the pediatrician now. Now the new pediatrician with whom she has to kind of get communicated. Echo showed a large problem which may necessitate intervention or surgery in the future. Mother was very unhappy with the pediatrician in her hometown, who failed to recognize the murmur, though he had seen the child thrice. So what's the diagnosis?
Atrial septal defect.
Excellent. Large atrial septal defect. Here you need not feel bad because in spite of the atrial septal defect being large, the shunt will not get established before 1.5 to 2 months, because up to 1.5 months, the right ventricular hypertrophy slowly regresses, right atrial pressure slowly comes down, and a good shunt gets established around 1.5 to 2 months. Only when the good shunt gets established, the right atrium and right ventricle will start enlarging, pulmonary will start enlarging, the flow murmur will occur. So you would have seen the child once or twice, you would have honestly examined the child clinically, and CVS examination did not show any murmur. Now the new murmur will develop, which the clinician will diagnose. And if your colleague says, pick up on I think it's not the right comment to make. Your colleagues, or we should very clearly say, no, this heart condition will not get exposed in that period. First 3-4 months, அந்த நேரத்தில் நீங்க குழந்தைய கொண்டு வந்தீங்கன்னா அப்போ எனக்கு கூட இந்த மரணம் தெரிஞ்சிருக்காதுன்னு we should say. Then that will be a kind of a correct way of counseling the parents also. So atrial septal defect is generally very well tolerated, and they will not get exposed by themselves because it's a well tolerated kind of condition, and clinically we can diagnose only with a murmur. Okay. So I'm just leaving a gap. I just gave a few clinical scenarios. If we have, we can go for the questions, or we can go for other indications of timing of interventions or whatever.
Yes, sir. Shall I start the thing, sir?
Yes.
You can stop sharing, sir.
Yes, sir.
Sir, and coming to to complete the things, critical CHTs, because we had a wonderful scenarios presenting with no murmur, or presenting with cyanosis, or presenting with shock, or presenting with failure. Okay. And how early or as well as how late these critical CHTs can present, sir? Because the PDA closure is dynamic. We can't say 100% this will close by 3rd day, 4th day.
Exactly. The PDA closure can be anywhere within 24 hours to even up to 1 month. So the presentation can vary accordingly. But most of the congenital disease where PDA dependent, say I can say 60 to 70% present by 1 week. Because 70% of PDAs close by 1 week. 90% of PDAs close by 1 month. Another 5 to 6% close by 3 months. And beyond 3 months, no PDA closes generally. So we can expect that 80% will present by 1 month's time. And if you see, all the critical heart diseases which are presenting in the neonatal period are having desaturation. Either they are duct-dependent pulmonary circulation, duct-dependent systemic circulation, transposition of great arteries, or total anomalous pulmonary venous connection. All of them will have a desaturation. There comes the importance of the so-called pulse oximetry screening. If you take other cardiac conditions which are very critical can present, or say severe coarctation of aorta, severe valvular aortic stenosis, severe pulmonary stenosis, they can present with heart failure. Most importantly, they will have both aortic stenosis and aortic pulmonary stenosis have very good murmur. So if you want to give me some example of a child with a significant murmur and serious heart disease, these are the two conditions: severe aortic stenosis and severe pulmonary stenosis. Other two valves, tricuspid valve and mitral valve, also can cause regurgitation and can cause murmur in the newborns, but it's a very rare condition. A severe MR causing heart failure in the newborn period is very rare. Around 3 to 4 months they present, even if they have severe MR. Severe TR producing failure is practically not known unless they have Epstein's anomaly, which will have desaturation again. Okay, so the murmur producing lesions are usually valvular lesions, not the left lesions in the neonatal period. So what are those valvular lesions? Most importantly, aortic stenosis. So coarctation of aorta will not have even murmur also. But many times they have associated bicuspid aortic valve, you might get a aortic ejection clip. So when you have features of heart failure, but no murmur at all, suspect two things. One is it coarctation of aorta or cardiomyopathy? They also can present the first 2 to 3 months. So I have a slide where I am telling that if somebody has features of heart failure plus a murmur, features of heart failure plus a murmur, it's some left direction. Features of heart failure with no murmur is something like a coarctation of aorta or cardiomyopathy. Features of heart failure with a desaturation, say 83, 88%, 92%. A simple left right stent should not have any desaturation, isn't it? You have the same features of heart failure. Clinically, it's not cyanosed. You thought this is going to be a large VST, a large PDA. When you do the saturation comes to 92%, 90%. This is admixture physiology. So he may be harboring a single ventricle, tricuspid atresia, and things like that. So very, very clinical. See, clinically also, we also diagnose only this much. We will not diagnose tricuspid atresia clinically. We will not diagnose single ventricle clinically. Clinically, I also diagnose, is it a simple left rotation? Am I dealing with admixture physiology, or am I dealing with something else? Okay. So with murmur, without murmur, a short murmur, features of heart failure, left rotation. Short murmur, features of heart failure with desaturation, admixture physiology. Good murmur and heart failure, valvular lesion. No murmur at all, heart failure, either coarctation or cardiomyopathy. This summarizes most of the heart failure presentation in the first 3 months. Sir.
Okay, sir. So to continue with the murmurs, actually, murmur in a newborn is a tricky issue. Really a tricky issue. And murmur in the first hours, for example, as soon as the baby is getting resuscitated and baby is fine, when you see a murmur, what to do? Or murmur in the postnatal rounds by 6 hours, what to do? Or murmur in the about 2 weeks or 3 weeks, what to do. Whether we should be aggressive in referring to a pediatric cardiologist or cardiologist and do the echo, or whether we can be passive and because we find everything is fine and the baby is having murmur, because we doesn't want to create anxiety in the mother, which will affect the breastfeeding. So we found if everything is fine, only the murmur is there, whether we can be delaying the echo done. So I want answer to all these things, sir. The murmur in the initial house, how to interpret and go about, and murmur in the newborn period, how aggressive or slow we should be.
So as I showed you, as we have discussed, yeah, murmur is not an indicator of a serious heart disease in the newborn period. So just because there is a murmur, we need not worry. Many a times the murmur in the newborn period, whether you have detected on at 3 hours of life or whether at day 3 of life, 3 common causes. One, or the most common, is mild narrowing of the origins of both branch pulmonary arteries. You know, the main pulmonary artery comes and divides. At the origin, there will be some turbulence which will cause a murmur. Second thing is a mild valvular turbulence or mild valvular pulmonary stenosis. The third thing is a small patent ductus arteriosus. These 3 things will cause a ejection murmur in the newborn period. There is no urgency at all. If the child is otherwise fine, there is no urgency to immediately get an echo at that point of time. At the time of discharge, you can reassess them, say day 3 or day 4. And if there is persistence of murmur on day 3 or day 4, I think we should get an echo done because of not missing a serious conjunctival disease. By all means, you have checked the pulse, it's normal. You have seen the saturation is normal. Child is otherwise normal, feeding normal, everything is fine. When the child is having a murmur, he is going to have one of the 3 things, whatever I have mentioned. Either it's a mild narrowing of branch pulmonary arteries or mild pulmonary stenosis or small PDA. However, by doing an echo, we can do 2 things. We'll be having 2 benefits. One, we clear the doubt from our mind that we are not missing a major congenital disease. That also will reassure the parents. So better not to postpone the echo beyond, say, 3 or 4 days at the time of discharge. There is no recommendation to do on day 1. Now, when do you do on day 1 itself? If there is any kind of desaturation in the child, if there is any kind of sickness in the child, if the child is sick, the pulses are not palpable, the child is acidotic or child is having desaturation, whatever maybe, anyway, you can get an echo done on day 1 itself. Otherwise, in a normal child, we can always wait.
Can I make a comment, Dr. Palniraman, with your permission?
Yes, sir.
Sir, Dr. Kannan, sir, this CHD in a neonate is very close to my heart, sir, because I worked in the NICU for 34 years. Regarding the murmur, one who are able to click the diastolic murmur in a neonate, it is abnormal, pathological, unless proved otherwise.
Always.
Always.
There is no normal physiological diastolic murmur.
And
so whatever.
Immediately after birth, or say about 24 to 48 hours, if the second sound is loud, it is abnormal. You are missing some the devastating problem. And you said between the duct-dependent and duct-dependent systemic, among the 2, the ductal problem is have some buying time. Certain lesions you can easily save, whereas the systemic perfusion, systemic dependent, it is always devastating. You have to act fast. Those days are gone, waiting for an adult cardiologist in the NICU just to see the PA pressure. Whether I am dealing with the pulmonary hypertension in a neonate or first 48 hours, it always sometimes transient. It will anyway, it is going to reverse also. So these are all the things regarding the murmur I wanted to mention about it. And screening a critical heart disease, as Dr. Palniraman mentioned, it is not the murmur, it is the high index of suspicion. You have shown X-rays, beautiful X-rays. Those X-rays are still a nightmare for a neonatologist who is doing the duty on receiving the child and seeing a crashing child. You should have an index of suspicion to pick up the critical heart disease, especially systemic dependent heart disease. Excellent.
So what Dr. Jalil has highlighted is that any diastolic murmur is abnormal. There is nothing called a physiological diastolic murmur. So whatever we are, or functional diastolic murmur. So whenever we say functional murmur, we are referring to the short systolic ejection murmur. Even a long pan-systolic murmur cannot be a functional murmur, right? So yes, ejection murmur is the one which can be functional, which can be some of the reversible conditions. All other conditions will have some other lesion inside. So to allay the anxiety of the parents, the message for the previous question is that if you have a reasonably or well-heard murmur, even at the time of discharge, see, on day one, you are hearing daytime, the murmur has discharged, murmur has disappeared. You are happy because basically the PDA has now closed or the so-called turbulence has disappeared and things like that. If there is no murmur, there is no need for discharge. Just because you had a murmur on day one, there is no indication that you should do an echo and rule out. But persistence of murmur, one can always go for an elective echo.
Sir, actually, another thing is, apart from the murmur, actually all the pediatric cardiologists insist on S2, but it is very difficult with the fast heart rate in the newborn period. Is it really reliable?
No, sir. No, actually, even I myself will see that, though we have been repeatedly telling it's not so accurate, sir. Even for us, it's difficult. For teaching purpose, we tell them so that it goes into the mind. Whenever we talk to students, whenever we talk to young colleagues, we tell them just for teaching purpose that will make them to think that is there a real murmur, is there a real variation in the heart sounds. But based on second sound alone, diagnosing heart is going to be difficult, sir. I totally agree with you.
Okay, sir. So in short, okay, sir. Balashankar, sir, unmute, sir. Unmute, sir. Balashankar.
In older child, it is useful.
Yes.
Definitely, it is not in a newborn and infant. Second sound, I think, with the higher heart rate, it's very, very difficult. It's very, very difficult.
Okay.
Yes.
So in short, now it has been clearly given the message that is about the critical heart, congenital heart disease in the first session. Now, second thing, the murmur and the sensitivity and specificity of murmur in a newborn period is only 50%. Like,
Yes.
For example, you can miss a heart disease 50%, you can diagnose a benign condition 50%. So it is not sensitive and not specific. So have a murmur with a pinch of salt. That is the second message. Okay, now you have the murmur. Now you refer to the echocardiologist for the echo. My thing is echo by an adult because pediatric cardiologists are not available in each and every corner of the in Tamil Nadu or anywhere. So echo by an adult cardiologist or a pediatric cardiologist, how common significant discrepancies can arise?
As I said, anything related to IAS and IVS, they will easily pick up. So no AST is missed. Most of the VSTs are also picked up. Okay. Something related to greater arteries might be missed. For example, like as I said, they would have diagnosed tetralogy of Fallot, actually it could be double outward right ventricle. Okay. They may not be able to pick up the pulmonary veins. So the discrepancy comes only the pulmonary vein related diseases or great artery related diseases, whereas the diseases which will involve one of the four chambers or the valves are not generally missed. But anyway, you won't be stopping short, isn't it? Our aim is the adult cardiologist is going to give you a screening echo only. His echo is not the final echo. That will immediately kind of make you more vigilant and refer the child properly to another center. And hence, he is going to do a very good job. So adult cardiology will not say everything is normal for an abnormal heart. As I said, the only condition which will deceive him, which will be a normal in every other means. Pulmonary veins are normal, atrium are normal, ventricle are normal. Only thing the great arteries are wrongly positioned, which he is not able to diagnose. So in the newborn period, an adult cardiologist can miss a transmission of great arteries. He will not miss a large VST. He will not miss a tricuspid atresia. He will not miss a mitral atresia. He will not miss a cardiomyopathy. He will not miss an aortic stenosis. All these things will be picked up by the adult cardiologist also. So great artery related diseases and probably pulmonary related diseases only will be missed. So definitely we can depend on your colleague because most of the adult cardiologists who are practicing adult also have some exposure to pediatric also. And one thing which they do not do routinely is suprasternal view for the coarctation of aorta. I don't think there's a mental only the parasternal view and apical view only are commonly done for most of the adults, and they stop with that in children also. Whereas we do subjectified view, apical view, high parasternal view, low parasternal view, and then suprasternal view, and then put together the entire diagnosis. Unless we do the suprasternal view, we will not be able to diagnose coarctation of aorta. So if you suspect clinically lower limb pulses are not well, you should specifically inform the cardiologist. Please look at the soup, and he'll be able to diagnose. Not that he cannot diagnose coarctation of aorta, because he doesn't do suprasternal view, he misses it. But if you kind of prompt him, sir, I'm thinking about coarctation of aorta, please kindly rule out, then he'll rule out that also. So I can say most of the 80 to 90% of the diagnosis will be got by the adult cardiologist also, who has some exposure to pediatrics. Fine tuning or maybe further fine tuning of the other things will be done by the pediatric cardiologist. Like then maybe an additional VST. It can be actually a DY, not DY, and things like that.
Dr. Palniraman, with your permission, again, yes, regarding the views, the adult cardiologists will use the apical, whereas neonatal or pediatric, they will use the suprasternal or substernal. What is your comment on that, sir? They prefer only the apical, the adult.
Not preference, sir. They have been taught only parasternal and apical views. Whereas we have been taught to see from all angles because we don't miss anything. So it's not their preference. That's what they know. Suppose I do have so many of my colleagues coming and getting exposed to our unit. They stay for 3-4 days or just 1 day. And then when they go back, they start doing sub-FR also. 2 months before, I did one pediatric echo workshop at Chengalpattu Medical College. Now I hear that most of the students and assistant professors, they're all doing sub-FR suprasternal also very well. So it's basically they need to be told certain views and they all will pick up.
As the functional echocardiogram workshop, we are tuned to the parasternal and the suprasternal views only, sir, pediatric.
Functional echocardiography, even apex is enough, sir. Apical view, I can tell you, as I said, 80% or 85% diagnosis can be made in apical view.
Yes, sir. Yes.
Apical view, if the pediatricians learn the functional echocardiography by only one, it's not apical view, apical sweep. In the sense, we put the probe at the apex, go posteriorly up to coronary sinus and gradually lift it up to the aorta. You will see so many structures and 80 to 85% of diagnosis can be made, and that's one of the excellent thing to be learned by all the neonatologists.
Sir, our doubt is whether it is neonatologists confirmed the lesion, it has to be confirmed by the adult cardiologist also? No, sir. Once the neonatologist suspect the heart disease, immediately that becomes an indication that a pediatric cardiologist should be involved. Basically, our aim is to pick up the disease. Let me tell you, the neonatologist who is very much active in cardiology wants to do an echo. He is doing repeated echoes and they are coming normal. There is nothing to feel disheartened. If you have suspected 100 times that there could be heart disease, but 19 times it was normal, but the 100th time it is really abnormal, you are really saving the child. So kindly don't feel bad for having suspected heart disease and then it turns out to be normal. Okay, it is absolutely right. It's absolutely right for you to have suspected the heart disease, and even if it comes to normal echo, it's absolutely right. That gives you peace of mind to concentrate on other diagnosis and treat the child much more accurately.
Sir,
hello.
adult cardiologists நிறைய நேரம் மிஸ் பண்ற மாதிரி இருக்கு சார்.
அதான் சார் சொன்னார் outflow tract and inflow tract ரெண்டுத்தையும் வந்து usually they can miss. That is the message Dr. Kannan wants to give. Uncoarctation
of aorta. Greater arteries, pulmonary veins, coarctation of aorta.
Yes.
These are missed. So when you have the suspicion, you should always get another echo.
Sir, for example, now we are going for a resuscitation call. A practitioner, new practitioner is going for a resuscitation call. And actually the obstetrician says, sir, this is a patient with high risk for CHD. There is a family history of CHD. Mother is a diabetic on drugs like anticonvulsant like phenytoin or any sodium valproate. And how the pediatrician what protocols he should follow after resuscitation, this newborn. Whether immediately he should go for echo screening or what else.
So there won't be any difference in your resuscitation techniques because the child will be delivered normally. Whatever the disease you said, they are all having a very low risk of inheritance. Of all the congenital diseases, most of the time the inheritance is less than 1%. The obstructive diseases, say maternal aortic stenosis, maternal coarctation of aorta, left heart obstructive disease, only they have some kind of inheritance like 5 to 7% of recurrence in the children. Otherwise, most of the other congenital diseases, they are sporadic. They don't kind of involve their children, except in some forms of ASD and things like that. So our resuscitative measures, nothing is going to change. We are not going to do any extra medicine. We are not going to have any extra finding also. So these children, they became a candidate for an elective echo later. If you haven't kind of in-house cardiologist at the time of discharge, you can do an echo, or you can tell the parents at the time of discharge, கொஞ்சம் ஒரு வாரம் 10 நாள் கழிச்சு இந்த இவர்கிட்ட போய் கொஞ்சம் எக்கோ மட்டும் பண்ணிடுங்க, ஜஸ்ட் ஃபார் ரொட்டீன் ஷேக் அப்படின்னு சொல்லிக்கலாமே ஒழிய there is no timing for this, sir.
Sir, Balashankar sir, anything from your side you can start.
ஒன்னும் இல்ல சார், very clear actually. Sir, அதான் this is the functional murmur தான் சார். Okay, it is for newborn, yes, it is difficult. What about the older stage, our 5 years, 6-year-old child வருது? We are not sure that it is a Still's murmur. Beautiful murmur. Is it enough to say that clinically itself that this is a murmur which is not going to cause any harm, or is there any possibility of having heart disease down? Is
Sir,
it mandatory to do echo in all these children?
Oh, sir, my answer is yes. In say 1994, when I was doing my MD pediatrics, 94, 95, echocardiography itself was rare. You see the queue in the echocardiography, long queue will be there. And hence, most often at the time, the echo trained pediatric cardiologist was also not there. So that time this debate was there, to do or not to do an echo. In the current scenario, any child with murmur should have undergone one echocardiogram. If the echocardiogram is normal, nothing to be worried. Thereafter, even the murmur persists into adulthood, nothing to be done. But just because there's a simple murmur and child is asymptomatic, we should not assume that everything is normal. So definitely the message is, if there is any murmur in any child, yes, the child should have received one echo.
Yes.
There is no need to repeat it one echo.
As facilities are now available, I think we should go, because yes, the school health referee, murmur no varo. We'll pediatric functional murmur dane. But it is safe to submit them for echo and rule out a heart disease than just convincing them that is a functional murmur only and saying that. Thank you, sir. Thank you.
Yes. Regarding the resuscitation again, the obstetrician asks for the sterilization second day or even on the table.
On the table, second day on the table they will ask.
Suppose because we always cared about the ongoing heart disease or presenting heart disease. What is your suggestion for the neonatologists, whether they can give sterilization consent or we have to wait for 72 hours?
Sir, it's an extremely important question. It's an extremely important question. I would say it makes no sense for the obstetrician to ask us, LSCS பண்ணிட்டு இருப்பாங்க, இந்த பக்கம் திரும்பி டாக்டர் செலக்ஷன் பண்ணலாமான்னு கேட்பாங்க. எனக்கு தெரியாது மேடம் தான் சொல்லணும் நீங்க. See, if a excellent fetal echo had been done and fetal echo had been reported as normal, you can say heart was normal. Okay? And if excellent fetal anomaly scans have been done, and if they had ruled out most of the anomalies, and now when the child is otherwise okay, maybe you can say, all parents are okay, madam, based on the previous reports, I agree. But otherwise, if you're not happy with the prenatal echoes, if you're not happy with the prenatal scans, you should say, I cannot be sure, I cannot rule out anything at this point. It's up to you to decide. So I will tell our obstetrician gynecologist that the decision of doing sterilization on table should have been taken beforehand, not after delivery. At the time of delivery, the decision will change only if the child has had some kind of, neonatal asphyxia or some other newly developed problem. Suppose the gynecologist mentally had prepared to do the sterilization, but at the time of delivery, unexpectedly some new finding has come up. Then she should not do the sterilization. She will wait till the child is kind of, well settled and then think about sterilization. Otherwise, the decision of going for sterilization should have been taken beforehand, not after deliveries. So if they are asking you, you should simply say, "Enak theriyadhu madam." Neenga dhaan decide pannum.
Sir, now coming to, for example, antenatal scans. Sir, na 5 scan pannom, 6 scan pannom, and postnatally, because even in UK, TGA has been missed 80% of the times. Even in UK itself, that is antenatal scans are missing the thing. So in a country like India, how commonly you can miss a CCHD, critical CHD, as well as benign conditions by antenatal scans? And what is the advice we should give?
Your very topic, sir. Simple actually, sir. Benign conditions, we are not worried. Antenatal diagnose panna major cardiac diseases. Again, let us come back to the same thing, sir. If you have seen the fetal echocardiograms and the 4-chamber view, easy ellarum eduthuruvaanga, sir. All radiologists also will take 4-chamber view, atria and ventricle. In the 4-chamber view la pathina, tricuspid valve சரியா develop agaliya tricuspid atresia, mitral valve சரியா develop agaliya mitral atresia, hypoplastic left heart syndrome. Okay, so pulmonary atresia, hypoplastic right ventricle, large ostium primum defect, large ostium common AV canal defect. இந்த மாதிரி most of the diseases தெரிஞ்சிரும். But tetralogy of Fallot கூட great artery அவங்களுக்கு பிடிக்க முடியலனா கூட large VSD தெரிஞ்சிரும். So most of the major congenital diseases will be diagnosed by the so-called 4-chamber view in a fetal echo if the radiologist is good enough to get a 4-chamber view. So rest of things தான் மிஸ் ஆகும். அதே மாதிரி great vessel related and pulmonary related. For example, if you take me, even I am not 100% sure of diagnosing or ruling out TAPVC many times. Even if I am not 100% sure of not missing a coarctation of hypertension newborn. Great vessels, of course, we can easily pick up. So again, what we say is that we have ruled out major congenital diseases, most of the major, but still there's a 10% element of new finding occurring after birth. We always tell this to the parents. We always tell them that there is a limitation of the technology. Right now, based on whatever we have, whatever our understanding, still there can be 10% new finding after delivery. So I would like to give you 100% prognosis of the child only after my echo, after the delivery. So you have to accept that. The normal echo doesn't mean totally normal subsequently. Now coming back to the second question, எப்படி அவங்களை கவுன்சில் பண்றது? On the so-called medical termination of pregnancy, earlier it was 20, now it has extended to 24. The reason for keeping it up to 20 was that, if a child is born before 20 weeks, there's a very less possibility of child kind of surviving and becoming, subsequently surviving. So because the chance of survival is so low below 20, doing an MTP is considered to be, என்ன சொல்றது, ஒரு உயிரை நம்ம கொல்லலைங்கிற மாதிரி எடுத்துக்கலாம்னு சொல்லுவாங்க. But it's all very kind of, not a very hard and fast rule. Now, coming to the importance of diagnosing serious congenital diseases between 12 weeks, 16 weeks, and 20 weeks. Before 20 weeks, we should diagnose. The advantage is MTP. Now, serious congenital disease is one for which there is no good surgical outcome or there is no good other outcome and child cannot survive. For example, somebody has hypoplastic left heart syndrome. Somebody has single ventricle with pulmonary atresia. Somebody has truncus arteriosus with hypoplastic pulmonary artery. All these are serious congenital diseases. So, ஒரு மதர் கேட்டாங்கன்னா சார் என்ன சார் நடக்கும்? சைல்டு டெலிவரி ஆகிற வரைக்கும் ஒன்றும் ஆகாதுமா. நீங்க தான் அதை அம்மா தான் பார்த்து போறீங்க, குழந்தைக்கு ஒன்றும் ஆகாது. டெலிவரி ஆன அப்புறம் சர்ஜரி தேவைப்படும். அப்படியா சார் டாக்டர், ஒரு சர்ஜரி குழந்தை சரியாயிடுமா? இல்லம்மா, குழந்தைக்கு 2 இல்ல 3 சர்ஜரி தேவைப்படும். ஓகே சார், 3 சர்ஜரி பண்ணிட்டேன் டாக்டர், அப்போ நார்மல் ஆயிடுமா, எல்லாரும் மாதிரியும் வளருமா எல்லாம் கேட்பாங்க இல்லையா? இல்ல சொல்ல முடியாதுமா. சாதாரணமா இந்த மாதிரி குழந்தைங்க இந்த 3 ஸ்டேஜ் சர்ஜரி பண்ண அப்புறம் ஒரு 15 வருஷம் 20 வருஷம் வாழ்வாங்கங்கிற உண்மையை சொல்லிடும். Because there is a 90% probability of surviving up to 20 years, even if you do everything good for these children. ஐயோ டாக்டர், அப்படியா டாக்டர், அப்ப நாங்க என்ன செய்யறது? நீங்க முடிவு எடுக்கணும். I will never commit and say that you please go for MTP because it's their decision. It should not be our decision. Our thing should be to put forth the prognosis. I have seen some parents who are very, very kind of, affectionate, say that whatever may be done, let the child be born, I'll take care of the child as long as child is supposed to live in the world. அந்த மாதிரி பேரண்ட்ஸ் கூட இருக்கிறாங்க. ஆக நம்ம ப்ரொக்னோசிஸ் தான் சொல்ல போறோம் இல்லையா? அதை பொறுத்து அவங்க தான் டெசிஷன் எடுக்கணுமே ஒழிய we can aid in their decision making. We need not kind of cover up certain facts or we not exaggerate the facts. We'll give the facts as such and deal. For example, the large VST இருக்கும், உடனே MTP பண்ண நிற்பாங்க. அப்ப நான் இன்னும் இது கரெக்டே கிடையாது, இது நீங்க துரோகம் பண்றீங்கன்னா ஒரு வார்த்தை கூட பண்ணுவேன். என்ன VST இருக்கு, நிறைய நேரம் ஸ்பான்டேனியஸ் க்ளோஷரும் ஆகலைன்னா ஒரு சர்ஜரி இருக்கு, முடிஞ்சு நார்மலா போகுது. இதை போய் இந்த சிசுவை நீங்க அழிக்கிறதுக்கு எப்படி ட்ரை பண்றீங்க? அதெல்லாம் கிடையாது டாக்டர், எனக்கு நல்ல சைல்டா வேணும் அப்படின்னாங்க. ஒரு சைல்டு நல்ல சைல்டா நார்மலா வளருன்னு வைங்களேன். இன்னைக்கு கையில் வளர்ந்துருச்சு, அந்த சைல்டு 70 வயசு வரைக்கும் வளரும்னு அப்படி நீங்க சொல்ல முடியுமா? There are so many other aspects which is going to act on that particular child. ஸோ அதனால நீங்க அதை மட்டும் வச்சுட்டு பிசிக்கலி நல்லா ஒரு குழந்தை பிறந்துட்டா மட்டும் 70 years வரைக்கும் நார்மலா இருக்கும்னு சொல்ல முடியாது. ஸோ அதனால அந்த aspect. So whenever the outcome is good, I rather try to insist them not to go for MTP if they have made up the mind for MTP. On the other hand, if this is a critically, definitely severe disease where the prognosis is not very great, I'll try to have a slightly discouraging tone in my discussion, but I will never say you can straight away go for MTP. I'll say you take the decision and they'll understand.
So another small thing in the antenatal scan, sir. Echogenic foci சொல்லிட்டு நிறைய ரிப்போர்ட் வருது. And what to do, sir?
That simply warrants an echo postnatally. I am yet to see any abnormal diagnosis just because there is an echogenic focus, sir. Some echogenic foci patients also have VST. Some have even common echocardial defect. Some are even tetralogy of failure. But அதெல்லாமே diagnose ஆயிருக்கும். இது எதுவுமே இல்லாம வெறுமே echogenic focus இருக்குன்னா பிறந்ததுக்கு அப்புறம் ஒரு எக்கோ எடுத்து நார்மலாக சொல்லிக்கலாம் சார். பட் இது எக்கோஜெனிக் ஃபோக்கஸ் ஜெனரலி ரிலேட்டட் டு பேப்புலர் மசில்ஸ், மைட்ரல் பேப்புலர் மசில் ரிலேட்டடா இருக்குன்னு ஏதோ ஒரு தியரி சொல்லுவாங்க. I am yet to find an abnormal echo just because there was an echogenic focus in the fetal scans.
Sir,
I want to ask one question. You told this counseling and all. What are all the congenital heart disease that are diagnosed in utero? Even with this advanced management and surgery techniques, you told us some children, they die within 15 years. What are all those things which we have to give that caution to them? And we have also to be cautious so that we can tell them the right thing. Because the intervention of cardiac surgery, we are able to correct. There may be some disease which I want you to tell, which is definitely very, very difficult to correct at this moment of time.
Yes, sir. So straight away, I put this one. Okay. So cure abdina PDA. Idana near cure, large AST, VST, pulmonary stenosis, coarctation, near cure. Abna, we have to do the intervention. Intervention panappuram, they are going to be normal. Seringla. So this is a completely good diagnosis, good prognosis. Excellent results. Tetralogy of Fallot, TAPVC, AV canal defect, TGA. All these are one-time surgeries. Some tetralogy of Fallot may need re-intervention later. But otherwise, most of the TAPVCs, all TAPVCs, or say 95% of TAPVCs, 95% of common AV canal defect, 95% of TG are one-time surgeries. One surgery per child is going to be normal. So, cure, near cure, excellent result. This is reasonably good result. Reasonably good result. They need 2 or 3 surgeries. Tricuspid atresia, single ventricle, double aorta right ventricle, reasonably good result, but they need 2 or 3 surgeries. But even after doing all these kind of surgery, they'll undergo so-called Fontan operation. After that, their survival is around 25 to 30 years only as of now. 15 years are push panni 20-25 years vara kondu vandirukrom. Idha avangata open ah sollinu. Now in the first 3 vara varaikum, I'll be very strong in them not to go for MTP. I'll discourage them in going for MTP in the first 3. Obviously, PDA we won't diagnose intrauterine. Ostium secundum AST we won't diagnose intrauterine, but primum AST will diagnose intrauterine. So the AST, VST, PS, coarctation, AST is aortic stenosis is AST, VST, PS, AS, coarctation, TOF, TAPVC, AVCD, we can encourage them to continue pregnancy. Whereas here we can be kind of neutral or rather giving a slight discouraging tone. Truncus arteriosus, pulmonary atresia, so if pulmonary atresia can do a good job, yes, we can do a good surgery and we can correct the ventricular septal defect. Because there is pulmonary atresia, we will put a tube, we put a conduit, artificial conduit from right ventricle to the pulmonary artery. Now, we'll put a tube, say right ventricle to pulmonary artery. The size of the tube will be with regard to the size of the child, isn't it, for the newborn period or in the infancy. When the child grows, the heart will grow, the tube will not grow. So after 5 to 6 years, we have to redo the surgery and change the tube. Again, after 8 to 10 years, we have to change to another tube. So and every redo open heart surgery carries 3 times the risk of the original risk. So though there are some kind of intervention available, the overall outcome is not very great. So this is the fetal scans. Caution. So I'll go to the next slide. So complex congenital disease high priority. You discourage just continue positive think TAPVC, TJ, AVC, TY. See, there are treatments are available. If you are really keen, continue out into. Straight away discourage hypoplastic left heart syndrome, heterotaxis syndrome, discourage. So I think this slide is very clear. This slide we can remember. And in the first 3, no problem.
Slide. Wonderful slide.
Wonderful slide, sir.
Wonderful slide.
Wonderful. This is the most important slide. Fantastic.
Okay. Thank you, sir. Next question.
Kanan, post neonatal common CHDs and how to proceed with them. For example, mainly we are concerned about the AST, VST, and PDA. These are the 3 common post neonatal common CHDs. Whether we should wait for spontaneous closure, whether we should go for surgery as early as possible, whether we can delay the surgery, and along with the TOF also. These 4 are the common things which we see in the post neonatal period.
Yes, sir.
Either with failure or with cyanosis.
Yes, sir. So again, I'll go for some other PowerPoint.
Watch.
Okay. Sir, again, I hope it is visible again.
Yes.
Yes. So the timing of intervention depends upon, now what's the natural history of the lesion? Is the thing going to close spontaneously, or even if it is present, there is no going to be any problem? What's the benefit of therapeutic intervention? What's the risk of therapeutic intervention? In the மூணுமே பார்க்கணும் for any lesion, depending on the age of the child also. A particular intervention may be very high risk in the newborn period, but it may be a low risk in the 6-month-old child. So our decision depends on all these three things. And if the natural history is better than the procedural outcome, do nothing. If the results after surgery intervention is better, do something. We are going by that. So we'll go by this now. Now, AST, timing of intervention. Primum AST, we electively operate after 1 year. The child will be asymptomatic. So beyond 1 year, we subject the child for surgery. Sinus venosus ASD, we wait for a period of 2 to 3 years and then subject to surgery. Now, why the difference? Can we wait a child with primum ASD? Can we wait beyond 2 to 3 years? There is no hard and fast rule. We can do at 2 to 3 years also. But we should remember that the primum ASD is also associated with cleft anterior mitral leaflet most of the time. And hence, there will be various degrees of mitral regurgitation from mild to moderate to severe. So depending on that, if there is only cleft anterior mitral leaflet and if the mitral regurgitation is mild or less than that, we can wait maybe 2 years, 3 years. Anything more than mild is better to intervene early so that the ventricles won't dilate, you don't have any problem. So for primum ASD, it's around 1 year. Sinus venosus ASD, as you all know, the gap between both the atria is high above near the SVC, and 99% of the time it is associated with partial anomalous connection of the right upper pulmonary vein to the SVC. So when they do surgery, they have to route the SVC to the right atrium and the pulmonary vein, right upper pulmonary vein, to the left atrium. So in doing so, they need to have enough room for that. They should put a patch in such a way that the pulmonary vein should go to the LA and SVC should come to the RA. And there is a slightly higher risk of narrowing of one of the two. Either the SVC to RA junction may be narrow or the pulmonary vein to LA can be narrow. So that to make the surgeon to be much more comfortable to operate, we are waiting for 2 to 3 years. Okay. Beyond 3 years, it doesn't matter. For a newborn, for a pediatric cardiac surgeon who is operating on a small children of 1.5 kilo, 2 kilo in the 1 and 2 months old time, it's not a big deal for him to operate on sinus venosus ASD also. On the other hand, there's no urgency also. Why should you send a sinus venosus ASD child at the 1 month or 2 months old for surgery? Okay. So for primum ASD, around 1 year. For sinus venosus ASD, 2 to 3 years. Now let us come to the common second-term ASD. Child is totally asymptomatic, which is in 95% of the time asymptomatic. Around 3 years. Okay. So device closure or surgery. The child is symptomatic, even at 8 months, 10 months, around 1 year, any age we have to do. And it is not uncommon. I can say, at least being a kind of, referral centers, we see more. But I see at least one child in 3 months or 4 months where child has only ASD, but coming with heart failure or poor weight gain, failure to thrive. So in that case, generally the ASD is very large and we'll send the child for surgery even before 1 year. So in general, asymptomatic ASD around 3 years. Symptomatic ASD, whenever you diagnose, you better to go for surgery. So this is regarding the ASD timing of intervention. So now I'm just putting the question. A 2-month-old child found to have a large ASD by echo. What would you advise? Nothing to worry at present. No drugs. No relation to RTI, even when the child is, which is that every child is bound to get. Because heart or water you should clearly tell there is no relation to the respiratory tract infection and the ASD, whatever you have diagnosed. Repeat an echo after 2 years because ASDs can come down in size. And ASD as large as 8 millimeter diagnosed at birth can spontaneously close at 1 year. But I'm not asking to repeat after 6 months or 1 year because what's the use of repeating at 6 months and 1 year? We are going to take the decision only at the end of 2 years, isn't it? So I will directly say the Marandan, child nalla irukka 2 வருஷம் கழிச்சு கூட்டுவாங்கன்னா எக்கோ பார்க்கறேன். இடையில எக்கோ பார்க்கல அட்வான்டேஜே கிடையாது அப்படின்னு சொல்லிடுவோம். Because only that time you have to take the decision. So in an occasional child, as I said in the previous slide, less than 5% of the time, this could be a reason for failure to thrive. The large AST could be a reason for failure to thrive when early intervention could be indicated. 5-year-old child found to have a small AST. What is your advice? Nothing. மறந்துருமா இருந்துட்டு போட்டு உங்களுக்கு என்ன பண்ண போகுது? Don't worry, don't do repeat echo, just leave it. இந்த 100 பேர் உட்கார்ந்துருக்காங்கன்னா அதுல எல்லாருக்கும் எக்கோ எடுத்தோம்னா 15 பேருக்கு இப்படி இருக்கும். PFO is present up to 25% of the individuals, adults. Of the 25%, if you measure the size, many are more than 5 to 6 millimeters. So it's so commonly seen in adults. No need to go behind this, just forget it. No need for repeat echo. Now come to the next common topic, ventricular septal defect. So spontaneous closure is most common in muscular defects. Next common is perimembranous defects. The line is very important. Majority of small perimembranous defect will close, but only a minority of large perimembranous VST will close. முன்னாடி the subaortic கொடுப்பாங்க. Now people have recognized not using the term subaortic VST term use பண்றது இல்ல. Majority of small perimembranous VST will close. அப்படின்னா ஒரு 10% of perimembranous VST, even if it is small, it won't close. It will just continue like that. Subpulmonic and inlet defects do not close. They do not close. Subpulmonic and inlet defect, they do not close spontaneously. So VST சொன்ன உடனே முதல்ல நம்ம என்ன பார்க்கணும், என்ன டைப் VST பார்க்கணும். அதுக்கப்புறம் தான் நம்ம வெயிட் பண்ண போறோமா இல்லையான்னு முடிவு எடுக்கணும். மஸ்குலர் VST டெஃபினட்டா வெயிட் பண்ணுவோம். 8 months 1 year கூட வெயிட் பண்ணுவோம்னு சொல்லணும். பெர்மெம்பரன்ஸ் VST கொஞ்சம் வெயிட் பண்ணி பார்க்கலாம் அப்படின்னு சொல்லணும். சப்ளமானிக் VST இல்லைன்னா வெயிட் பண்ற அர்த்தம் இல்லை சார், நீங்க உடனே சர்ஜரி போங்கன்னு சொல்லணும். So large VST na 3 to 6 months is the usual timing. Earlier surgery can be done if the child develops heart failure. Moderate na 1 to 2 years. Again, earlier the child develops heart failure, failure to thrive or pneumonia. Small na no surgery or no interventions needed. We need to just follow by 1 or 2 yearly follow, because small VST can sometimes develop aortic valve prolapse and aortic regurgitation or infect endocarditis. For that reason, we need to have a medical follow for small. So the thing is, decision making is for large VST. In the large VST also, if it is subpulmonic VST and inlet VST, no discussion at all. Straight away sending the child for surgery. If it is a large perimembranous VST, we can say the child overall okay தான் இருக்கு 2 மாசம் ஆகுது, ஒரு 1.5 மாசம் பார்ப்போம். Because those large VSTs which are destined to come down in size or reduce in size will show up in another 1 or 2 months. இப்போ 4 months ஆயிடுச்சு, எக்கோல அதே மாதிரி தான் இருக்கு. Child rather weight development கம்மியா இருக்குன்னா you have to send for surgery. If you are not going to wait indefinitely, think that this large VST is going to close or come down in size. So ஒரு 1 to 2 months ஒரு large VST பார்த்தா நான் உடனே சர்ஜரி சொல்ல மாட்டேன். பெரிமெம்பரன்ஸ் VST ஒரு 1 month கழிச்சு வாங்க, ஒரு 1.5 month கழிச்சு வாங்க, மறுபடியும் எக்கோ எடுத்து பார்ப்பேன், டிஃபரன்ஸ் பார்ப்பேன், ஏதாவது கொஞ்சம் சுருங்கி வருதான்னு பார்ப்பேன். So we can give a kind of 2 to 3 months time to see whether that particular VST has an inclination or intent or a tendency towards spontaneous closure. But by 4 to 5 months, we should have taken a decision and send the child for surgery. Another 6 months. 6 months, beyond 6 months, we should not allow any large VSTs to go on, because it is going to cause pulmonary vascular disease and problems. This is the perimembranous VST. Large VST, many times it will start coming down in size. I have seen so many large muscular VSTs becoming a moderate VST, and around 1 to 2 years, I have done a transcatheter closure. At 1 or 2 months, it would have been a large muscular VST. At that point, only surgical indication would have been there. But after waiting, that would become a moderate VST. And after 1 year, I would have done a transcatheter closure. So, அந்த மாதிரி ஆகலாம். So, நான் சொன்ன மாதிரி muscular VST இருந்தா வெயிட் பண்ணலாம். Perimembranous VST னா கொஞ்சம் வெயிட் பண்ணலாம். Subpulmonic VST and inlet VST, no waiting at all. PDA, same. Large to moderate PD na 3 to 6 months, surgery or transcatheter closure. Small na 1 to 2 years. Silent PD na closure is not recommended. That is clinical murmur ஒன்றும் கிடையாது. By chance எக்கோ எடுத்தப்போ ஒரு சின்ன PD இருக்குன்னு வரும், அதை நம்ம அப்படியே விட்டுறலாம். Nothing, there is no risk of increased infected endocarditis. But it's a very standard recommendation. Coarctation of aorta.
Sorry for interruption, Kanan.
Yes, sir. Yes, sir. Yes.
Whether PDA can close, small PDA can close by 3 months in a term babies?
Sir, maximum 3 months waiting, sir. Any PDA which are destined to close will close by 3 months.
And medical treatment, only for medical treatment, only for preterm PDA, not for term PDA.
Sir, any PDA, sir, any PDA, even preterm, even term PDAs, you have diagnosed at say 10 days time or 2 weeks time. As I said, 90% close by 1 month. Term PDA தான் சொல்றேன், spontaneous closure தான் சொல்றேன். Not with medications. It's not medication induced. It's a nature.
Okay.
By giving
so medication is only for preterm.
Only for preterm.
Yeah, because by giving medications, you cannot induce closure for a term PDA. Absolutely wrong concept.
Okay.
Whereas preterm PDA, we routinely give medications and try to close the PDA. Okay. So
Okay.
what I'm saying is natural evolution children.
Okay.
Naturally, when you allow all the term PDA also to just to continue, 90% will close by 1 month, and by 3 months, practically every PDA that are destined to close would have closed. If it is not closed by 3 months, then we have to do something subsequently depending on the size of the PDA.
Okay.
Okay, sir?
Okay, proceed.
Right. Now, coarctation of aorta. Newborn coarctation of aorta is often associated with LV dysfunction, congestive heart failure, and severe upper limb hypertension. Immediate intervention, surgery. So, no delay at all. For newborn coarctation, day 1 diagnosed on surgery, day 2 diagnosed on surgery, day 5 diagnosed on surgery, because the child can develop LV dysfunction anytime, develop congestive heart failure at any time. And if you suspect or you subject a child with heart failure to surgery, is much more riskier than a relatively stable child with coarctation. So coarctation, there is no waiting time at all. Once you diagnose coarctation, surgery. If the coarctation is diagnosed in the later infancy and childhood, that means the child has tolerated. Child has tolerated the coarctation and grown. And if there is the pressure gradient between the upper limb and lower limb is more than 20, or the pressure gradient across the coarctation is more than 20, that becomes an indication. Beyond 6 months, we can do balloon and subsequently stenting more than 10 years. Here, we have to see the anatomy and decide whether ballooning is better or surgery is better. If the coarctation is discrete, coarctation is membranous type. If the arch is otherwise well grown, they'll give a reasonably good result with balloon dilatation and subsequently stenting later. But if the arch is not well developed, there is narrowing of the distal arch, and the coarctation is not discrete, then surgery will give a better result. So our decision of sending an infant or a child to surgery or ballooning depends on the anatomy of coarctation, not just coarctation per se. Like ASD, whether it's a device closure or surgery depends on the anatomy of the ASD. Similarly, here also we'll decide. But in the newborn period, the role for intervention is very, very small. If at all, let me tell you, suppose the child has a severe coarctation of aorta, heart failure, intubated, now ventilated, but there is no surgeon available in your center. It has to be transferred. Now, how to stabilize the child? Child is in a very sick status. We can give start prostaglandin, open up the PDA and perfuse the lower limbs if it is possible. Or what we do, we use the coronary hardware, coronary wires, coronary balloons, and try to do balloon dilatation of the arch of the aorta. And whatever improvement in the flow, that will give some time, that will reduce the acidosis, that will stabilize the child and allow us to shift the child to the place where they can do the surgery. So the role for intervention newborn coarctation is to buy time. Whereas in older children and infants and older children, intervention can be really a therapeutic one, this coarctation of aorta. So tetralogy of Fallot, total surgical repair is what we are aiming at. Not like we do some palliative repair and follow on. What about medical therapy in tetralogy of Fallot? We should maintain the hemoglobin to more than 14 grams. Because there is cyanosis, we need more hemoglobin for adequate oxygenation of the tissues. So oral iron is a regular supplementation for all children with any cyanotic heart disease, not in tetralogy of Fallot. If child has history of spell, the child has to be immediately subjected to some form of palliative therapy or total repair. During that waiting period, beta blockers are beneficial. So beta blockers are not a treatment to be continued indefinitely in a child history of spell. Because the next spell can lead to stroke. Next spell can lead to even death. So we cannot allow the child to develop another history of cyanotic spell. Even one history of cyanotic spell is enough for us to start beta blockers, stabilize the child, and refer the child to the surgery at the earliest. If the anatomy is good enough, directly the surgeon will go for total surgical repair. If the anatomy is not good enough, the surgeon will do a palliative shunt. But whenever we are giving beta blockers, it has to be in minimum 1 to 4 milligram per kilogram per day in 2 to 3 divided doses. Generally, we use propranolol and not the other beta blockers. So for pink fallow, child is totally asymptomatic. That's also not very rare. Child is completely asymptomatic, saturation more than 85%. There will be loud murmur. Pediatrician would have referred to me as VST. Clinically, they would have diagnosed small VST, which is correct. Because a small VST murmur and a loud ESM of a pink fallow cannot be differentiated clinically so well unless the pediatrician has seen the saturation. The saturation was less than 95. Then you know that it's not a simple VST. Okay, so in pink fellow, we do elective total repair around 6 months to 1 year's time. Okay, if there is severe cyanosis or swell, this less than 3 months, many surgeons will go for palliative surgery. More than 3 months, they go for a total correction. I think that summarizes the.
Yeah.
Yes,
okay. Thank you. Really wonderful thing for the thing learning. And now at this juncture, I want to ask, for example, we are waiting for the surgery and we are managing the CHF with the anti-failure drugs. Whether the age-old digoxin, furosemide, and partchlor are the ones which you are giving, or you are nowadays, because they told that in infancy there is no need for potassium chloride supplementation, and whether we have to add ACE inhibitor. What's your take on this? The anti-failure measures for during waiting period.
So during waiting period, furosemide is the one which has a very well established role. So furosemide to be given. Digoxin has well established absence of role. So no role for digoxin because there is no LV dysfunction involved. There is no arrhythmia involved. The role for digoxin in heart failure comes if there is LV dysfunction or say atrial fibrillation. So in older children, say rheumatic heart disease, atrial fibrillation, or some other LV dysfunction, one can still consider kind of digoxin. But in the infancy where we are considering the left direction, no role for digoxin. Yes, the only role, very important role is diuretics. We always give iron supplements, whether it's a cyanotic heart disease or acyanotic heart disease. We give supplements because iron deficiency is common, and lower hemoglobin is going to worsen or aggravate the failure. And then the role for the ACE inhibitors also, some studies support, some studies do not support. I am not in favor of that because my aim is in another 10 to 15 days time, I want the child to get corrected rather than postponing for 1 or 2 months. So it's not going to make a real difference by giving or not giving the so-called ACE inhibitors because the effect of ACE inhibitor is not going to be immediate, where the effect of diuretics is going to be immediate. The moment you start doing diuretics, in 2 days' time, you can say the mother will say the child is slightly better now because of the decongestion. But ACE inhibitor is not going to do any decongestion. It's going to try to reduce the peripheral vascular resistance and then reduce the pulmonary blood flow, which is not very easy also. The heart, the body balances the systemic vascular resistance and pulmonary vascular resistance to some extent. You try to reduce the systemic vascular resistance by giving ACE inhibitors, thereby trying to reduce the pulmonary blood flow. That doesn't happen so easily. So I am not in favor of any other medicine other than diuretics. Diuretics definitely benefit, but that's to buy time and to allow the child to go for surgery.
Okay,
so what about the VSD, sir? Large VSD, there is going to be LV dysfunction also, isn't it?
So
which will you prefer, digoxin or ACE inhibitor?
Sir, generally LV dysfunction is not a feature of large VSD, sir. If at all you want to use ACE inhibitor as the drug of choice. ACE inhibitor. Now, if you take PDA, the peripheral systemic vascular resistance is already low. A child will be in failure. So obviously you cannot reduce the already reduced systemic vascular resistance. In ASD, it has no role anyway. So if at all VSD, we can try ACE inhibitor along with diuretics.
Okay. Thank you.
Sir, like a PDA again, like a PDA, as Dr. Palniram mentioned, PDA in a term baby, there is no intervention. Same-wise, the hemodynamically significant PDA, that also need not warrant any intervention, sir.
Close. Yeah. Mute, please. Somebody.
Sir, hemodynamically significant PDA need not be symptomatic. Symptomatic PDA will be hemodynamically significant always. But the reverse is not true. A hemodynamically significant need not be symptomatic. Many times the child will tolerate very well. There will be like LA enlargement will be there, child may be asymptomatic. But depending on the flow, we always prefer to go because nowadays the transcatheter closure is relatively simple and straightforward. Beyond 3 months, we won't wait if it is a moderate or large PDA. Small PDA, we wait for 1 year because there is no real hurry. Beyond 1 year, we can electively do. But any moderate to large PDA beyond 3 months, we generally go for transcatheter closure and we generally have a very good result, relatively simple procedure. So, a symptomatic PDA will be hemodynamically significant. But all hemodynamically significant PDA need not be symptomatic.
Yes, sir. Cyanotic spell management at a clinic level. Because the patient actually morning becomes a floppy and becoming acidotic and tachypneic, and they are bringing to you. And what should we do at the office practice level for the majority of practitioners?
Yes, sir. The most important thing is IV fluids. Of all the treatment, whatever I'm going to tell. See, basically, now when the ventricles contract, the blood has two outlets. One is to the aorta, another one is to the pulmonary artery. Okay. Now, when the intravascular volume is low, the resistance in the aorta is much lesser than the resistance at the right ventricular outflow tract because of the tetralogy of Fallot. All the blood goes to the aorta. That causes cyanotic spell. Now, how can you make the blood to enter into the pulmonary artery in a much better way? Increase the intravascular volume. In tetralogy of Fallot, even if you pump in 10 liters of blood, fluid, pulmonary edema cannot occur, isn't it? He will develop peripheral edema, but pulmonary edema cannot occur because the pulmonary blood flow cannot be increased. So, one condition where generally in cardiac condition we will say restricted fluid or just mind your fluids, but here in tetralogy of Fallot is one where you should not mind giving a large amount of fluids. But to give large amount of fluid, child has to be quietened. First thing to give is to give morphine and quieten the child. Get an IV line and give you a 20 ml bolus and another 20 ml bolus and start the infusion. Okay. And then, other than these two, you want to increase the systemic vascular resistance. One very good drug which is underutilized, which will increase the systemic vascular resistance is ketamine. It also can increase the pulmonary vascular resistance, but our aim is to now here in tetralogy of Fallot, the pulmonary vascular resistance is low, but the resistance is not at the level of pulmonary arteries. The resistance is at the level of main pulmonary artery or subvalvular infundibulum. Our aim is to increase the systemic vascular resistance so that the blood, instead of going to the aorta, should try to go more into the pulmonary artery through the right ventricular outflow tract. So ketamine can be used as a sedation and also as a treatment for cyanotic spell. Other than these, all the other drugs, say oxygen, very, very doubtful benefit. You are going to give oxygen to the lungs. It's not going to enter the circulation unless the pulmonary blood flow is increased. It's not an abnormal lung. So normal entry of oxygen is good enough for the child to have oxygenation. So giving oxygen has very doubtful role. Giving soda wake-up, absolutely zero role. Absolutely zero role. Okay. So three things. Number one, you sedate the child, make the child comfortable, give morphine. Number two, immediately get an IV line, pump in lot of fluids. Third thing, increase the systemic vascularization by giving ketamine. And all the other things like phenylephrine, other things are again meant to increase the systemic vascularization. But these three things are commonly available. And if you do these things, then it's
what fluids, sir?
How about the Nietzsche's position, sir?
Yes, sir. All these are increasing SVR. Nietzsche's position, turning the child to one side, giving to Nietzsche's position is again increasing the SVR. We are bending all the vessels. Okay, we are improving the venous return. We are pumping the blood from peripheries, but bending the arteries and things like that, so that the SVR is increased and higher blood flow goes to the pulmonary arteries.
Beta blockers.
Beta blockers role comes. Yes, IV beta blocker can be given against to reduce the heart rate. That is IV beta blocker. After these three things, the next thing to do is to do the IV beta blocker to reduce the heart rate. Now, earlier people were thinking infundibular spasm is the reason for cyanotic spell. That's why beta blocker was given so much of importance. There is nothing called spasm in a cardiac muscle. Cardiac muscle is a cardiac muscle. It's not a smooth muscle. The spasm is a feature of a smooth muscle, intestinal muscles. Yeah, cardiac muscle, if it contracts, it has to relax. Then it can contract again. It cannot have the sustained contraction of so-called spasm. So there is nothing called infundibular spasm in cyanotic spell. Basically, when the right ventricular volume is small, the thick muscles in the RVOT remain collapsed, both in systole and diastole. It is not a spasm. The moment to enlarge the right ventricle outflow tract also opens up. That's why I said, how to enlarge the right ventricle, give a lot of fluids. Having this in mind, there was a strong recommendation of IV beta blocker and things like that earlier to treat cyanotic spell, but they have not been shown to be so effective in avoiding the spell or treating the spell. But definitely controlling the heart rate and subsequently beta blocker introduction is very beneficial. As I have to tell you that the propranolol, which is a non-selective beta blocker, increases systemic vascular resistance. Thereby it helps the TOF also.
Morphine எல்லாம் கிடைக்காது சார், அதனால அந்த ketamine and beta blocker is a easy
Morphine
medicine.
ஈஸியா கிடைக்கும் சார், வாங்கி வைக்கணும் அவ்வளவுதான். அதாவது எல்லாமே நம்ம அதுக்குன்னு ஒரு சின்ன ஒரு எக்ஸ்ட்ரா பேப்பர் ஒர்க் பண்ணணும். நம்ம ஒரு ஆம்பிள் வாங்கினா கூட என்னமோ 6 months or 8 months இருக்கு அது எக்ஸ்பைரி. As you said, metoprolol IV is available, but that's not a very good drug for the tetralogy fellow. IV propranolol is not very easily available. So orally we put rice tube or something, start oral propranolol, so it will take the effect and subsequently avoid. So which is the best drug to avoid subsequent cyanotic swell, avoid dehydration, give beta blockers. That is propranolol.
Sir, and about the soda.
Palani Raman, sorry to interrupt.
I
I think we are coming to the end, seeing maybe another 5 more minutes. Some questions from the chat box either in the report and just maybe to discuss. No?
Sir, ஐயோ முடிஞ்சு போச்சா? No, ஐயோ.
கொஞ்சம் திருமுறை கொஞ்சம் ஒரு 10-15
Yes, sir. Yes, sir.
Right, please. Thank you.
Sir, now we'll go to the rapid fire, sir. Now, rapid fire.
நானே பாத்துறேன் சார், क्वेश्चन ஆன்சர் நானே பாத்துறேன் சார், பாத்துட்டு கடகடன்னு ஆன்சர் பண்ணிடலாம் சார், no problem. Nobody should be left.
Yes.
So Dr. Nandini, we are using paracetamol for pediatric and preterm babies. Is there a benefit in using paracetamol for a term baby? The benefit is no, it won't help. Sir, is the TRPG, that is a triglyceride regression PG alone, is enough to diagnose primary pulmonary hypertension in newborn? Any PA pressure more than 30 is called pulmonary hypertension. If you have a triglyceride regurgitation, echo-wise you can diagnose the triglyceride regurgitation related RV pressure. RV pressure is supposed to be same as the pulmonary pressure. Adhanal primary pulmonary hypertension is diagnosed based on the triglyceride regurgitation. Suppose உங்களுக்கு triglyceride regurgitation கிடைக்கலன்னு வச்சுங்க echo-ல. When you look at both right and left ventricle by the short axis view, the intraventricular septum இருக்கு இல்லையா? The intraventricular septum, if it bulges into the right ventricle, that means the right ventricular pressure is less than 50% of the left ventricle. Okay. Suppose the intraventricular septum is flat. RV-க்கும் LV-க்கும் flat இருக்குன்னா RV pressure is same as LV pressure. If the intraventricular septum is bulging into left ventricle, then there is suprasystemic pulmonary hypertension. That is the other way of diagnosing pulmonary hypertension based on the echo. The question is by Galaxy A50S. Next question, Priya. Role of paracetamol for the treatment of pediatric is no role. Antenatal anomaly scan showing echogenic foci. Soliton sir already kettanga. No significance. Generally echo will be normal. TOF with pulmonary atresia or severe stenosis. Yes, TOF with severe stenosis, excellent results still available. Pulmonary atresia தான் கொஞ்சம் problem. நான் சொன்ன மாதிரி pulmonary atresia இருக்குன்னா we have to put a conduit from right ventricle to the pulmonary artery, and the conduit will not grow, and hence we have to keep doing the redo surgery. Redo surgery na ulla poi stent போடணும். So it kind of warrants multiple kind of reinterventions, and many times whenever there is a pulmonary atresia, pulmonary arteries may நல்லா grow இருக்காது. As you know, the outcome of surgical results of tetralogy fellow depends on the good size branch pulmonary arteries. The branch pulmonary arteries are not developed, then the surgical outcome is also not very great. And Dr. Nandini, another question. Inotrope of choice in a child presenting shock and also diagnosed coarctation of aorta is very difficult question to answer. Coarctation of aorta leave pannama, you cannot give any kind of improvement in the clinical condition. Here again, some cautious fluid therapy and early interventions should be the answer. No inotrope is going to improve the pulses because there's a mechanical obstruction. So I will say that better to avoid the inotropes, accept the lower blood pressure, but try to push the child for intervention at the earliest. இது வந்து Q&A ல இருந்தது. Chat something is there.
Dr. Palani sir.
Yes, sir.
Same thing only I put in the chat.
Rapid fire session, sir.
Fire.
Yes.
Another 20 minutes, 15 minutes. Sir, now we will come to another group, sir. Arrhythmias in infancy, presentation and red flags to diagnose in early infancy.
Arrhythmias are generally well tolerated in infancy, sir. Newborn period, one arrhythmia you can see atrial flutter. Okay. Atrial flutter arrhythmia on that. Again, heart failure will not be there. You can say very high heart rate, and usually DC shock is the treatment of choice, generally rather than giving any medication, but has a good outcome. Yes. Other than that, older children, the commonest arrhythmia supraannular tachycardia, again well tolerated. A child with a supraannular tachycardia, even if a heart rate of 300, will remain asymptomatic, but they will slowly go into so-called tachycardiomyopathy. So once you diagnose SVT, medical management is very much available. 80% of SVT diagnosed in the infancy will disappear spontaneously by 2 years. So we continue medical management for 2 years and then reassess and withdraw the medicine and see. If the SVT recurs, then we subject the child for EP study and radiofrequency ablation. But if a child presents with syncope or child can present giddiness following a palpitation, it's most of the time ventricular tachycardia. Ventricular tachycardia is very dangerous. Whatever may be the things, there are one or two benign ventricular tachycardias in children, so-called right ventricular outflow tract ventricular tachycardia, so-called fascicular ventricular tachycardia, benign. That is, the tachycardia vandalum, child will tolerate like a SVT. Medication also has good result. RF ablation also good result. But there are something called exercise-induced CPVT, catecholaminergic polymorphic ventricular tachycardia, long QT syndrome later ventricular tachycardia. They are very dangerous. So any giddiness or in fact symptomatic arrhythmia or VTs in general, whereas SVTs are usually asymptomatic. The timing of presentation vachi degree of or the severity chollam mudiyadhu. A severe arrhythmia can present very lately or very early also. So it depends on the symptoms and the nature of the arrhythmia.
Sir, beyond SVT, any other significant arrhythmia a pediatrician should have in mind?
So SVT
only atrial flutter you told. Another thing is
atrial flutter, SVT and the AVNRT, AVRT, PGRT, ectopic atrial tachycardia. There are so many. When I say SVT, I include all the SVTs.
Okay.
The commonest SVT is WPW syndrome related in the newborn period or infancy, but all other SVTs can occur. Ventricular tachycardia, I think recently I sent a manuscript on arrhythmias in children to one of the books, Dr. Sarchola. So maybe there I have reviewed this chapter, sir.
Sir, your approach when you encounter a child with syncope, a child is referred for syncope to you. What are the things you do, sir?
Yeah. Syncope, most important part is the history, sir. What made the child to develop syncope? And very close differential diagnosis is the seizure disorder in children. So structural diseases in syncope is very small. Aortic stenosis, aortic stenosis only can present with syncope. Otherwise, structural diseases syncope role small. So clinically, Murmur and aortic stenosis diagnosed pannidom. So echo enna sollum, echo la LV dilatation LV dysfunction irukanu sollum. Arrhythmia is the reason. So what we do is we do a basal ECG, basal echo, and clinically we analyze and subsequently put the child on Holter monitoring. And depending on the condition, we will decide how far we should go. Now, the ventricular arrhythmias can commonly present as syncope. Most of the time, if the syncope is real and recurrent, one of the two things are possible. Child is having ventricular arrhythmias, easily long QT syndrome, or we have wrongly diagnosed the seizure disorder as syncope. So rent angling, I won't hesitate. Even if I think strongly there is a cardiac cause, I won't hesitate to send to a neurologist to assess from his angle to do EEG and other things to rule out the so-called seizures as the cause of the syncope. So commonly X-ray, ECG, echo, and subsequent Holter monitoring. Currently, Holter monitoring is available for 24 hours, 3 days, 7 days, 1 month, or even 3 months. So most of the times we pick up those things. And if something is kind of, very rare recurrence, then only we have so many other things like implantable loop recorders. But these are the usual investigations done, sir.
Sir, whether routine...
One comment. Sir, if the syncope, you have to ask for the precipitating factor. If there is pain or some sight of blood or something is precipitating syncope, it is likely to be vasovagal. If there is no precipitating insult, but the child gets recurrent syncope, then it's likely to be organic, some cardiac problem or something like that. So that is most important thing to differentiate.
History-wise, definitely. That's why I said history is what the precipitating factor, what he was doing at that time, how he fell, how he recovered, whether it was a transient loss of consciousness, how long he lost. At the time of recovery, was there any movements of limbs? What happened to the sensorium thereafter? The whole history should be written as a story. Whenever somebody writes the history of syncope, it's not one line, he had syncope day for his No, it's the whole history. That's going to give a lot of clues. And our further is basically based on the history. That's why initially I said the most important thing in evaluation of syncope is history.
Yes.
Yes, sir. So syncope in short, whether we are dealing with a vasovagal or cardiogenic, and mainly cardiogenic occurs mainly during exercise or during action, and usually they won't have any prodrome. That is mainly like any dizziness or anything they won't have. And vasovagal is the most common and most commonly occurs in the thing. Okay, when coming to chest pain, sir. What about a chest pain? Yeah, and how will you evaluate when a patient comes to you with
Chest pain in
chest pain
children,
or palpitation?
there is no single cardiac condition which can cause chest pain in newborn or infants or even early childhood. So if a child comes with chest pain, you can simply examine. There is no cardiac condition which can cause chest pain. Even if you consider Kawasaki disease can cause coronary lesion and chest pain is beyond 8 to 10 years. Before that, I have not seen anybody coming with chest pain with Kawasaki disease. And all the cardiac conditions, whatever we are discussing, will cause either dyspnea or cyanosis. Chest pain, or very, very rarely even dizziness and syncope. So of the 4 cardinal signs of cardiology, so-called chest pain, dyspnea, syncope, and palpitations, palpitation can occur in pediatric heart diseases, syncope can occur in pediatric heart diseases, cyanosis can occur, but chest pain is very rare. So chest pain in pediatrics, reassurance only is what the mainly treatment is needed. Generally, no further evaluation is needed.
Sir, and when you come across a patient with irregular heartbeats, whether exercise test alone is enough to rule out serious rhythm disturbances?
Sir, one ECG எடுத்துலாம் sir. ஒரு ECG எடுத்துலாம். என்னன்னா அந்த irregular heartbeat most common thing is sinus arrhythmia number 1. Next common is occasional atrial ectopics. Okay, இந்த ரெண்டுமே நீங்க சொன்ன மாதிரி ஒரு சின்ன எக்ஸசைஸ் பண்ணி ECG எடுத்தோம்னா ரெகுலர் ஆயிடும். இந்த ரெண்டும் டிசப்பியர் ஆயிடும். இந்த ரெண்டு நம்ம மேற்கொண்டு ஒன்றும் பண்ண போறது கிடையாது. ரீஅஷ்யூர் பண்ணணும் அவ்வளவுதான். ஆனா டாக்குமெண்ட் பண்ணிடலாம் இல்லையா? அதுக்காக irregular heartbeat ஒரு ECG எடுத்துருங்க. எடுத்துட்டு ஒரு 10 தடவை சிட்டப் பண்ணிட்டு மறுபடியும் ECG எடுத்துருங்க. ரெண்டையும் டாக்குமெண்ட் பண்ணி அவங்ககிட்ட கொடுத்துங்க, முடிஞ்சது. So rather than assuming
ECG, exercise, ECG and document and
regular basal ECG, ஒரு சின்ன ஒரு another ECG, முடிஞ்சது.
Exercise. Yes, sir. Sir, coming to the rheumatic fever, application of new Jones criteria and fallacies, whether Tamil Nadu comes under high prevalence zone or low prevalence zone, whether because India comes under high prevalence zone, whether the new criteria we have to apply the thing.
We have to apply because we are still in the low. We have become the low prevalence zone actually.
Okay,
because sir. Kerala, in the last 1 year, I have seen only 2 children of rheumatic fever. Last whole year, only 2 children. But in adults, older children, adults, we get rheumatic heart disease still. So the silent rheumatic fever is ongoing. We are still getting rheumatic mitral stenosis. We are still doing balloon mitral valvolectomy, though at a lower level. But the incidence of clinical rheumatic fever has come down drastically.
Next to benzathine penicillin, what is the drug you recommend, sir, for secondary prophylaxis? Because
erythromycin is very well tolerated and very well tested, sir.
What, sir? Another
erythromycin. Erythromycin.
Okay. So what is your preference, sir? Particularly the patient refuses benzathine penicillin.
Oral penicillin. See, benzathine penicillin, then oral penicillin, then erythromycin.
Right. Sir, you are coming up, you are mainly
oral penicillin is better absorbed in the empty stomach. So I'll insist that you should take in the empty stomach.
Empty stomach. Sir, hypertension, basic minimum investigation for incidentally detected hypertension.
Any hypertension in child is abnormal. There is we should consider that it is a secondary hypertension unless proven otherwise. So there is nothing else basic investigation. All investigations to be done. So we are starting clinically. We should look for electrolytes. Among the electrolytes, high potassium is for Conn syndrome, high aldosterone and related Conn syndrome. Okay, urea creatine 2 for renal disorders. So you do an ultrasound abdomen for kidneys, suprarenals, and things like that. You do echo for coarctation of aorta, ECG to again see for LVH. So there is a series of investigations, including urinary VMA, this, that, CT scan, contra CT scan abdomen. Everything has to be done till you reach the diagnosis. If all these things have been done, then only you can say it is probably a primary and start treating medications. So in pediatric hypertension, there is nothing called basic investigation. Every investigation has to be done.
Every investigation has to be done. Sir, and for example, you see a murmur, sir. What is your way of examining quick cardiac examination for tips for the practicing pediatrician? These are the things I will see examine in a clinical examination when you come across a murmur in a older child.
If you allow me, I'll again share my slide, and whatever I told earlier, I'm going to kind of that will be very good. That will be very good, and that will be very useful also.
Yes.
I'll just try to share that one particular slide.
Yes. Through last 5 minutes, pa mudichiram pa.
Okay, boss. Okay, boss.
பாருங்க இது பாருங்க சார், இது பாருங்க ஏசான் நான் வந்து கிளினிக்கலா மர்மரோ மற்ற கிளினிக்கல் எக்ஸாம்ஸ் போறதுக்கு முன்னாடியே மனசுல டயக்னோஸ் வந்துடும் சார். சொல்றேன் கேளுங்க. சைல்ட் இஸ் ஏசானாட்டிக், தட் இஸ் சேச்சுரேஷன் நார்மல், செஸ்ட் ஆக்டிவா இருக்கு, ப்ரீகார்டியம் ஆக்டிவா இருக்கு, இன்ட்ராகாஸ்டல் ரெசிஸ்டன்ஸ் இருக்கு, அதெல்லாம் இருக்கு, மர்மரும் இருக்கு. மோஸ்ட்லி ஐ அம் டீலிங் வித் லெஃப்ட் ரைட் அண்ட் போஸ்ட் ட்ரைகஸ்பிரஷன். ஓகே, சைல்ட் ஏசானாட்டிக், ஆக்டிவ் செஸ்ட் பட் மர்மரே கிடையாது. நான் அப்போதே சொன்ன மாதிரி கார்டியோமயோபதி அல்லது கோஆக்டேஷன் ஆஃப் அயட்டா. தேர்ட் சைனாட்டிக், அதாவது டீசாச்சுரேஷன் 88%, 92% இருக்கு, ஆக்டிவ் செஸ்ட். அப்படின்னா என்னது? அட்மிஷன் பிசியாலஜி. நான் கிளினிக்கலா எக்கோ பார்க்கறதுக்கு முன்னாடி என் மனசுல இது இருக்கும். அப்புறம் சைனாட்டிக் சைல்டு, ஆனா கோஆக்ட் செஸ்ட்னா மர்மர் இல்லைன்னு சொல்ல, மர்மர் இருக்கும், ஆனா ப்ரீகார்டியமே ஆக்டிவே கிடையாது. செஸ்ட்ல வந்து அந்த இன்டர்காஸ்டல் ரெசிஸ்டன்ஸோ சப்ளைட் ரெசிஸ்டன்ஸோ பால்பல் பல்சேஷனோ கிடையாது. ஸோ கோஆக்ட் செஸ்ட் பிளஸ் சைனோசிஸ் டிஓஎஃப், ஆக்டிவ் செஸ்ட் பிளஸ் சைனோசிஸ் அட்மிஷன். Active chest, no cyanosis, left direction. Very simple. I also follow the same thing in the OPP. On the other hand, prominent murmur, no failure at quiet chest, small shunt and some valvular heart disease. This reach further is PSA, is ASA, is mitral regurgitation, and further fine tune our diagnosis. Whereas here, I don't need to fine tune my further diagnosis further because panna mudiyadhu. இப்போ டாப் பிசியாலஜி டயக்னோஸ் பண்ணுவேன் ஒழிய இது டிஓஆர்வி விஎஸ்டிபிஎஸ் டயக்னோஸ் பண்ண முடியாது. ஸோ இது அட்மிஷன் பிசியாலஜி டயக்னோஸ் பண்ணுவேன் ஒழிய இது ட்ரைஸ்பிரட்டரி சேவா சிங்கிள் வென்டிகுலான்னு சொல்ல முடியுமா கிளினிக்கலா? முடியாது. ஸோ அதனால இந்த ஃபர்ஸ்ட் 4 things இஸ் அ கிராஸ் ஃபங்க்ஷனல் டயக்னோசிஸ். ஐ எம் நாட் ட்ரைங் டு மேக் அன் அக்யூரேட் டயக்னோசிஸ். Whereas when the murmur is the main thing, then I can go further to so-called accurate final diagnosis.
Okay.
சார் ஒரே ஒரு கேள்வி சார், வாட் இஸ் த ரோல் ஆஃப் எக்ஸ்ரே அண்ட் இசிஜி டுடே? ஒரு மர்மர் கேக்குது, ஏன் நான் எக்கோ நேரா பண்ணிடக்கூடாதா, ஏன் நான் இசிஜி எக்ஸ்ரே எடுக்கணும்?
இல்ல சார், for learning purpose we can always do an chest x-ray and ECG. அந்த ரெண்டுலயுமே இட்ஸ் மோர் ஆஃப் நெகட்டிவ் ப்ரெடிக்டிவ் வேல்யூ சார். அதாவது பாசிட்டிவா இருந்ததுன்னா இட் வில் கைண்ட் ஆஃப் கோயிங் டு ஹெல்ப் யூ. இப்போ again I'm just going to share this alone.
Yes, as you shown in neonatal CSCHD, it has a really utility value in
yes, sir, that's what I'm
pulmonary
saying.
atresia and TAPVC.
Exactly. பாருங்க சார், role ECG is normal in most of the serious congenital disease. A normal ECG doesn't rule out a heart disease. On the other hand, நான் வந்து ஜூனியர்ஸ்ட சொல்றதுல அந்த மூணு பாருங்க, ECG எடுங்க, is the QRS is right word. If there is RV dominance, other QVS in 2-3 AVF, இந்த மூணுல எது இல்லைன்னா கூட abnormal ECG. That will not tell us the diagnosis, but it's abnormal. So நம்ம வந்து நிறைய லேர்ன் பண்ணியிருக்கணும் கூட அவசியம் கிடையாது. QRS axis ரைட் வேர்டா இருந்தா அது நார்மல், ஆர்வி டாமினன்ஸ் இருந்தா நார்மல். ஸோ ஆர்வி டாமினன்ஸ் இல்லாமல் இருந்தாலோ எல்வி டாமினன்ஸ் இருந்தாலோ அப்நார்மல். QRS axis நார்மலா இருந்தாலே அப்நார்மல். QRS axis லெஃப்ட் வேர்டா இருந்தா இன்னும் அப்நார்மல். QVS 2-3 AVFல இருக்கணும், வேற எங்கேயா இருந்தா அப்நார்மல். ஸோ இதை மட்டும் பார்த்தா போதும், இதை லேர்ன் பண்ண தெரிஞ்சா போதும் ஃபார் ரோல் ஆஃப் இசிஜி. ரோல் ஆஃப் எக்ஸ்ரே இஸ் a big topic சார். டிபெண்டிங் ஆன் த யூட்டிலிட்டி, நியூ பார்ன் பீரியட்ல வேற மாதிரி, கொஞ்சம் ஓல்டர் சைல்ட்ல வேற மாதிரி, grown up children வேற மாதிரி இருக்கும்.
Okay.
As more of learning purpose, as you said, echo is going to give the final diagnosis. But அனுப்புற முன்னாடி நீங்க ஒரு மனசுல டயக்னோசிஸ் அனுப்பிச்சு அதே ரிப்போர்ட் வந்து அவங்க சந்தோஷமா இருக்க முடியாது.
That is it. Clinical satisfaction.
Exactly. Clinically you have, see, I also myself
diagnosis.
See, I am echo of diagnosis பண்ணி, see, Dr. Balasankar has sent me this diagnosis. I will show to all my juniors also. Next time that will give a positive booster for subsequent further diagnosis also. So let us not forget our basics and learning of EC in chest X-ray. Though the utility is low, but the utility is there.
Thank you, sir. Thank you.
Really, actually, you did it, BRJ sir. Really, it was a really fantastic session. It was a overall things, mainly the cardiac issues has been covered. Mainly the critical CHD mostly can be picked up by routine examination, femoral pulse and pulse ox screening during the newborn period. So pulse ox screening and femoral pulse is very important, in particularly to rule out critical CHD in the newborn period. And you have clearly told neonatal murmur is a tricky issue to be sorted out carefully, and the limitations of antenatal scans practitioners to be aware of. And except for small VST and AST, operate before first birthday and give them as as a birthday gift, or sometimes you can postpone. So this is the main thing. And exercise test in irregular heartbeat is a valuable clinical tool. And exercise-induced and family history are important red flags for detailed evaluation in a child with syncope, and the timing of the heart surgeries. And you have covered most of the things, everything. So thank you. Really, we had a wonderful time. Hope the actually the delegates are benefited. Any other questions? 1 or 2 questions, if it are there, we can take the finally. And mainly this session is mainly to not to miss a critical cyanotic CHT in the newborn period, and how to deal with the post neonatal CHT is the thing. That is the main thing, and the bird's eye view of the syncope and other small things. Yeah.
Thank you very much, sir.
Thank you, sir.
I think we had a brilliant session. It was obviously, as Dr. Niranjan sir has put, it is a nice bird's eye view of entire pediatric cardiology. Nothing else can sum it up better than that few words. So thank you very much, sir. It's always a great pleasure to listen to Dr. PRJ, who is basically a mentor to me. So I'm very happy that I had another opportunity to listen to him. And my closing comments from our president, Dr. Balashankar, sir.
Sir, thank Dr. Padanaman and Dr. VJ, sir. Excellent, sir. You have done a fantastic job, and very clear and crisp guidelines to each and every one practicing pediatrician. I hope 80 people, around 80 people have attended. Everyone would have benefited, got at least 4 or 5 carry-home messages today on listening to this 1.5 hour session. Thank you very much, sir. Thank you so much.
I also really enjoyed. Thanks for the opportunity. Thank you very much. Thank you, sir. Good night.
Thank you, sir.
Thank you, sir. Good night, sir. Good night.
Good night.
Thank you, Thiru. Thank you.